The audience has asked Alper, what is your local anesthetic dose suggestion for pediatric electrospinal block underwent USD ultrasonographic guideline?
Thank you again, Mert, and thank you for a valuable question. Due to the limited time, I couldn't explain the detail of the subject. We apply ESP block to pediatric patients as much as possible as well. It's very easy to apply and relatively safe. In our hospital, there is only bupivacaine as a long-acting local anesthetic. We use a bolus of 0.2 or 0.25% bupivacaine in the volume of 0.5 milliliters per kilogram, with aspiration every 5 minutes per injection, all we know, into the fascial layer. After tip positioning was confirmed by careful hydrodissection with the saline, we do not exceed a dose of 2 milligrams per kilogram of bupivacaine in pediatric patients, and we determine by the age and weight of the patient. Thank you.
Okay.
Thank you, Albert. Yes,
okay.
there are questions for Laszlo as well. The first question to Laszlo: what about the influence of intrathoracic pressures during invasive ventilation in the theater and arterial pressure curves? Is the delta really reliable? What do you think, Laszlo?
Oh, let me answer first the first part. What about the influence of intrathoracic pressure? So the PPV, the pulse pressure variation, but the other methods too, I mean the systolic pressure variation, or the stroke volume variation too, are methods based on the concept that as intrathoracic pressure varies while a patient is being ventilated with positive pressure, venous return to the heart varies inversely with intrathoracic pressure. That's the basic for PPV monitoring. And this effectively will provide a mock fluid bolus with each breath, predicting how a patient will respond or not to a fluid challenge. That's the principle of pulse pressure variation. Now, is the delta really reliable? Don't forget the limits that I showed you, the slide by Michard and the group of Jean-Louis Teboul, the French group, about the applicability of pulse pressure variation, the limits. The limits states for L is low heart rate, respiratory rate ratio, like in extreme bradycardia and high frequency ventilation. I is for irregular heartbeats. M for mechanical ventilation with low tidal volumes, and low means already 8 milliliter per kilogram, which is not so low. I means increased abdominal pressure in other circumstances. T is open thorax, is normal, there is a huge proportion of false positive, and S is spontaneous breathing. So LIMITS. These are the limits. Of course, open thorax is the delta really variable. Let me say, before the majority of algorithms were based on the CVP for preload. Nowadays, they are assessing PPV and through PPV preload. If it's not reliable, then I don't know how we can use all the monitoring devices that we have. For sure, during thoracic surgery, we are really biased, that's sure. That I cannot answer you because I don't know, there are no studies about it. But that's my response to the question. Is it okay?
The next question is still for you, Laszlo. In this era of ERAS, enhanced recovery, would you recommend arterial line insertion for monitoring? Over the last couple of years, arterial pressure monitoring has become less commonly used. Any comments? Please.
I have one comment. First of all, what has ERAS to do with the arterial line inserting? I don't understand correctly, but now to insert an arterial line for lung surgery or lung anesthesia, I think that it depends upon, first of all, the patient, the type of surgery, the anesthesiologist, the skills of the anesthesiologist, of course, and institutional rules too. So if it's a young patient who is coming for really a minimally wedge resection, you know the surgeon is operating quickly, you know yourself, you are good, and institutional is allowed not to insert an arterial line, I wouldn't do it. If you are feeling more comfortable with an arterial line, do it. Of course, I won't do it for a lung transplantation or for a pneumectomy without arterial line. Second, ERAS means early recovery after surgery generally. Now, not inserting an arterial line will not facilitate recovery. Sorry to say, that has nothing to do with. But last couple of years, arterial pressure monitoring has become less commonly used in extreme patients, or maybe in patients in the non-intubated thoracic surgery. But that's something else. We could debate over it long. I maintain arterial line is, it depends upon patient and surgery foremost. Is it okay?
Thank you so much, Laszlo. Yes, Mert, please.
Maybe I can add something. So first of all, personally, I agree with you. If it is only for the intraoperative period, arterial invasive arterial categorization has less thing to do with ERAS. And for open thoracotomy, I think it is still a crucial part of the operations. You would like to see now and then some blood gases too. But moreover, and not just personally, I have to say, we in this, as you all know, in the Thoracic Subcommittee of the EACTAIC, we are now performing a big study, let's say, called TOSCA, and there we will define the operating procedures for the thoracic anesthesia. And this is actually also a part of the TOSCA, and therefore TOSCA is closely related to ERAS principles too, and therefore I would like to keep the interest of the audience, wait from us the results of TOSCA, and you will be amazed. Okay, so you can go on, Mohamed. Sorry.
Thank you so much, Mert. Yeah, it's a very good point. It was my comment as well. TOSCA will answer the consensus, European consensus within EACTA-IC about the use of invasive arterial blood pressure monitoring for thoracic surgery, and this chapter of general anesthesia and monitoring is chaired by Professor Tamas Beg, who was one of the speakers here, and it will be published this year, hopefully. Now I have several questions for Professor Bandan. The first one, if multimodal neuroimaging, including burst suppression monitoring, if nearest and may be able to predict and avoid post-operative delirium, how come we don't see a huge difference in studies regarding the outcome in terms of delirium between general anesthesia, spinal anesthesia, and local regional blocks, particularly in old patients and the frail patients undergoing hip surgery? And this is here as this delegate added, this has been published recently in North England Journal of Medicine. What do you think, Pierre?
How many time have we? No. Different things. I think first, I have read carefully this famous study about hip surgery comparing general anesthesia versus versus neuractial anesthesiology. And I think that the weakness of this sort of approach, and I well know the question because I was involved in one of the tasks of the EACTAIC 2 15 years ago. One of the problem, and we are thinking about that for the future, is that we have not to approach to have a global approach of the peoples. We have to consider really group of patient by group of patient, because a brain of 60, a brain of 40, or a brain of 80 are completely different. Second, there is a very large, this is one of the problem, very large inter-individual variations of the state of the brain circulation and the brain function of the patient. So that it is another element, which is a real limitation of this sort of results. And second, so we are trying to recommend to define and to predefine different states, cognitive states, neurologic states, vascular situations. And then when we took all these elements, preoperative element in account, then it seems that we could have more explicit results. Second problem is in sort of studies is a square effect, and to achieve and to have a small tendency to make the difference between the two kind of anesthetic techniques, we need thousand and thousand patients, and that is one of the limitations, because either American or European, and even working together, we are not able to have more than 20,000 patients or 30,000 patients. It's very large effective, and so for now this is very restrictive. Second point, I think that you talk about the variation of the EEG and the variation of the NIRS. No, not in this question. No.
There is another question. Mert, can you introduce it? Yeah. You're muted, Mert.
And just for finishing with the answer, my personal feeling is, in terms of brain, I'm not sure that there is a real difference between the neuractial. For me, peripheral blocks are on the side. This is completely different. But if we want to consider neuractial anesthesia and general anesthesia, I'm not sure that the brain perturbation would be really different. It's not so white and black for me. Excuse me.
That was it. Thank you very much. Okay. Then one more question for Mohamed. Do you have a question for another?
Yes.
Lecture?
There is a question for
yeah.
There is a question for Daniel. Do you think pleural ultrasound may be a standard technique in post-surgical cardiovascular monitoring without chest X-ray or in conjunction with imaging techniques? What do you think, Daniel? You can unmute yourself, please.
Do you hear me?
Yes.
Yes.
Okay. The question seems to be huge. You speak about, say the important words, the cardiothoracic surgery, that's it? Ultrasound for replacing X-ray in which setting?
Yes, in post-operative after cardiovascular surgery or thoracic surgery.
You say post-operative, that is after the theater.
Yes,
okay, because in the theater it would raise other problems of access to the thorax, but after the question is, I repeat, very wide. There will always be good to put, I ideally say stethoscope, but it is a stethoscopus in Greek, to put ultrasound on the thorax of these very heavy patients. I should say, how could we not insonate these patients after surgery? I'm not sure that I understand the question, but there are so many aggressions like pneumothorax, pneumonia, atelectasis, and I forget embolism.
Actually, Daniel, the question was asking if ultrasound in post-operative can replace chest X-ray.
Ah, that's the question. Yes, of course.
Yes, that's the main question.
Of course.
Yeah.
Of course. Yes, yes. I'm sorry. If it was the only question, the answer would be yes. Apart from inserting a venous line and knowing if you see me well? If the tip of the catheter touches the vein like this is, to my opinion, the last indication of X-ray. And one X-ray every 2 days is not a big deal for getting familiar documents. So I am not against making some X-rays, but not 3 per day.
Okay.
But for me, all these things have been validated since long. The superiority of ultrasound.
Okay. I have one question for Tamas. Actually, we have some more questions, but I will choose one of them. In the situations where no muscle relaxants can be used, I don't know whether there are some situations, but do you recommend in these cases using local anesthetic agents before intubating patient and after intubation is done? So before intubating patient, lidocaine spray on the vocal cords, and after the intubation, lidocaine within the endotracheal tube to suppress the airway reflexes. Tamas.
Yeah, thank you. So this is the case, the intubation of a myasthenic patient, a patient with myasthenic gravis. My answer is yes, you can use. I don't use. I prefer large dose of fentanyl, large dose of propofol, and a large dose of sevoflurane with a mask bag ventilation, and it's enough. The fentanyl, I think it's enough. But if you want to use, you can use. That's my question. It's your choice.
Okay, thank you very much.
I don't use. I think it's not necessary.
Yeah, but also in myasthenic patients, we use some, so low, half dose of neuromuscular relaxants, and it works. But we can come slowly to finish. I would say some words as conclusion, as take-home message. I think one of the most important take-home messages that we can have here is that we have to use the improvements in the technology also in our daily practice in the thoracic anesthesia, especially the improvements in ultrasound, lung ultrasound is good for many things. In my lecture, it was the proper positioning. In the lectures of Professor Lichtenstein and from Alper, we can see that we can use it to evaluate the lung pathophysiology and physiology, and we can use it for the vascular and vascular access and regional anesthesia. Moreover, we have to use other methods of monitoring too. In one way, we can use and we have to use neuromonitoring, because we monitor the heart, we monitor the lung, but what we are doing in anesthesia is something to do with the brain. Therefore, we have to monitor the brain too. That has been all the time also my conclusion. And moreover, a good neuromuscular monitoring and good appropriate neuromuscular monitorization, relaxation is can have very significant effects on the outcome too, and therefore Tamas has underlined these approaches. Last but not least, Laszlo has mentioned about fluid management, this is a big challenge. If you have an open thorax, and we can see that we can use the goal-directed therapy and goal-directed approach also under these conditions, knowing that we can have some limitations and we have to be careful about them. And I think this was all good. And I can now give the words to Mohamed for closing.
Thanks so much, Mert. At the end, I want first to assure all of you unanswered. We received a lot of questions, but we are behind the time. Any unanswered questions, it will be answered by each related speaker, and it will be posted in EACTAIC website. And later on, we will send a notification on social media, Facebook, Twitter, LinkedIn, and Instagram accounts. And finally, I am delighted to thank all esteemed speakers for this magnificent talks and their dedication and commitment. And I am delighted to thank all delegates and the speakers on behalf of the President of EACTA, Professor Patrick Waters, and the Board of Directors. And special thanks to the organizers from AIM Group and the team behind the stage from Multi-Learning, which are doing a great work. It is a reminder that this webinar is accredited to provide 2 CMA credit points from UEMS. However, you have to complete the survey feedback at the end to able to collect the CMA points. Special thanks to our main sponsor, Taba Medical China, and thanks to Edwards Life Science to providing unrestricted educational grants for this webinar. And thank you for everyone. And before we leave, I wanted to remind you about the next 2 events for EACTA. We have in April 11, the second episode from fellowship seminars on pulmonary hypertension and cardiac and non-cardiac surgery. Then we will have in May 9, the webinar from Vascular Subspecialty Committee on monitoring during anesthesia for vascular surgery. I hope you have a nice evening, and thanks so much for your joining. Bye-bye.